Welcome to the HealthspanMD Podcast. Welcome to the HealthspanMD Podcast, where we talk about the science of longevity. So anyone who's interested in longevity, you're probably interested in avoiding premature death, and you're going to want to listen to this podcast if that's the case, because we are going to talk about what prematurely ends over 300,000 lives a year in the U.S., and that is heart rhythm issues. And we have an expert in heart rhythm problems that I recently met, and I got to tell you, be prepared. She's amazing. So a little backstory. So, ER doctors and primary care doctors love having access to a cardiologist. And that's, typically not because of our winning personalities, but because these doctors know heart problems can be deadly. And it can be challenging at times to tell what is just annoying and what is potentially deadly when it comes to problems like chest pain and palpitations and passing out spells or syncope. Well, I got to tell you, cardiologists love electrophysiologists for those same reasons, because it's challenging at times to tell the annoying palpitations, syncope from the potentially deadly. And we're grateful to have those heart rhythm specialists at our at our disposal. So a little backstory. So I was on call one weekend at Mayo, and it was crazy busy, as it usually was. And I had a senior fellow with me, and there was a patient in the emergency room who had passing out spells, syncope. And so I was busy doing things. I sent the fellow there. The fellow's really good. And he comes back and he says, look, the guy's had lots of passing out spells. He saw EP yesterday. They think it's vasovagal. He's got a workup plan. We're just going to let him go home. And it would have been very reasonable for me to just say, oh, okay, I trust this guy. I trust my EP colleague. I'm not going to look into this any further because I have a list of about 10,000 things that I need to get through. But I've kind of always stuck with that, philosophy, trust but verify. And I said, okay, let me look at the EKG. And the fellow's kind of annoyed with me, like, you're going to delay these things. And he gives me the EKG, and it is consistent with a really rare heart rhythm problem that is potentially deadly called Brugada syndrome. And I'm like, this looks like Brugada. Sure enough, that's what this man had. It's still the only case I've ever seen in my entire career, but I stay up at night sometimes and think, wow, what would have happened if I would have just not looked at that EKG? Like, hopefully it would have turned out okay, but fortunately, through just good fortune, it turned into a story that ended up not being. It ended up being a story I wanted to tell rather than a story I didn't want to tell. So, today we are going to do a deep dive on that annoying versus deadly, the electrical systems of a heart, with an expert electrophysiologist, and we're going to answer these questions. When do you need to see an electrophysiologist? What are the biggest misconceptions about the heart electrical system, and when should we worry? And then we're going to do a deep dive on the most common heart rhythm problem we see, atrial fibrillation, and why, at least according to the experts, it's not being managed as well as it should be in many cases. And we are going to do all of that with Dr. Divyashree Varma, a highly respected EP doctor, and as you will soon discover, as I did, a wonderful human being. Welcome to the podcast, Dr. Varma.
Thank you, Dr. Hurst. How are you?
Oh, I am fantastic. I'm just so excited that you are here to help me and our audience understand the heart rhythm issues that you see and how you help people. So let's start with just telling our audience a bit about you, and then what is an electrophysiologist, and what does an electrophysiologist do?
So even though the spelling is hard, I'll simplify it for you. So think of me as the electrician of the heart. I try to explain to my patients that your general cardiologist is the contractor of the house. I take care of the electricals, and then we have my plumbing partners. So we take care of everything electrical with regards to the heart.
Beautiful. And so what are the problems that you commonly see? What are the things that are most prevalent in your practice?
So if I was to focus on one thing, and that's because it's, as age goes on, pretty much everybody's going to get it. 60% of the world population past the age of 60 would be atrial fibrillation. But right off the bat, the day you're born, some people are born with electrical conduction system abnormalities. As you grow older, some of you will develop, the more common at younger age being the SVTs. And that stands for supraventricular tachycardias. And the beauty of that is most of them are curable. As you get older, other rhythm abnormalities show up, concomitant with other cardiac disease, commonly being the coronary artery disease. After you have a heart attack, you develop scar in your heart. That relates to other abnormal arrhythmias, specifically the life-threatening ones like ventricular arrhythmias. You may have heard of people dying suddenly from that. So we treat all of those. But the bread and butter, commonest, and I think that we need to spread awareness about is atrial fibrillation.
Oh, we're going to do a deep dive into atrial fibrillation here shortly, no doubt. One thing I wanted to bring up is that there's not a lot of women in cardiology. I think it's about 10%. There's even fewer that are electrophysiologists. What led you to be EP, and how does being a woman in EP affect your practice?
So I would give credit to my father. And he's a big proponent of educate yourself, be independent, get a degree that's 10 years ahead of your time. So very supportive family. And I'm proud to say that as a woman, I've had a lot of men supporting me, and that's why I'm here. So I finished my cardiology fellowship, and then I wanted to do more. And I wanted a good mix of procedural and intellectual fields. And EP was growing at exponential rates, and it caught my interest. And that's kind of how I started looking at it, and I got accepted into subspecialty fellowship, and the rest is history.
Yeah, so EP, one of my favorite mentors, cardiologists, she would call the electrophysiologists the Star Trek nerds of cardiology because, and it's true because it is complex. I mean, the rhythm issues, when you get into channelopathies and
right.
there's a lot of depth to that. And looking at an electrophysiology study, all the little squiggly lines and things, I could see where somebody who is really passionate about those details could really gravitate towards that field. Yeah. So, in electrophysiology, we know that runs a gamut. Electrical problems of the heart are really common, and that could be anywhere from palpitations, which may or may not be related to the heart rhythm problems, but often, premature beats and those kind of things, all the way up to, as we've talked about, sudden cardiac death, either ventricular tachycardia or ventricular fibrillation, and everything in between. And then there's also just the diversity of the effectiveness of our treatment. As you'd mentioned, SVT, that's like a layup for you guys. Like, you see somebody that really has SVT that's really, affecting their quality of life.
Right.
I'm sure you're like, woohoo, this is, I'm going to fix this person.
Right.
How does our audience, when does something that is maybe just annoying, when do you get worried that it might be something that is life-threatening? What are the kind of signs that they should be looking out for to bring to their doctor's attention?
So the one thing right off the bat is the common faint. So any sort of passing out with exertion is not normal. So I would watch out for that. If you have no preceding symptoms prior to passing out, that's not normal. You want to talk to your doctor about it. You want to get referred to a cardiologist. A basic cardiac workup is mandatory in those cases. So that's probably the simplest thing I would start with.
Yeah.
If you begin to see that your symptoms or whatever it is you're feeling, whether it's palpitations, shortness of breath, lightheadedness, dizziness, is increasing, it is not getting better. It is associated with fatigue more and more. Your legs begin to swell up. You're having trouble breathing at night when you lay flat. Those are all bad signs. So you want to seek care right away.
Yeah, beautiful. That's another thing that I was taught as a fellow, distinguishing syncope or passing out. Like, that's a scary thing for everybody. And of course, there's, all passing out is potentially life-threatening depending on when you do it. If you're driving a car or in a swimming pool by yourself, that, the rhythm might not be the deadly, but the situation is. But most episodes of passing out or syncope are benign. We call them usually it's a vasovagal mechanism. My mentors taught me when I was a young cardiologist, if it happens in the bathroom, it's probably vasovagal. I always like that one. But I agree. I listen for that. Do you? Did this happen with exertion? And oftentimes that really needs details, because people will say, oh yeah, I was out for a run and I passed out. Ooh, my antenna's up. And then you get the details. Actually, they had stopped and they were, walking, and then that happened. So any of these symptoms, we're not here to diagnose or tell people when they should or shouldn't, but there are certain things that cardiologists are looking out for. These things can be warning signs. Talk to an expert and get their input on what may be something that needs to be addressed. Rhythm problems are a lot more prevalent, and people are aware of them because of technology these days. I wasn't that long ago. Was it 4 or 5 years ago that Apple came out with their rhythm monitoring on the Apple Watch device, and it was put out there at the time as that, well, this is life-saving. We are going to save lives with this. What's your experience been with the just widely available rhythm monitoring devices these days?
So I do use them in my practice commonly, but I don't use them as diagnostic tools necessarily. I use them as screening tools and long-term surveillance tools. Because what's important to understand is a lot of these algorithms are AI-based. And all AI essentially comes from natural intelligence to start with. These are pattern recognition that the human brain can't necessarily process, but a computer can. So it comes with its limitations. So you don't want to rely on them 100%, but for sure, I think they have allowed us to surveil patients long-term with convenience and provide data.
Yeah. So who are the people that you recommend one of these consumer devices to for rhythm monitoring?
So that's a controversial question, and whether we talk about AFib or just simple palpitations or extra beats from the bottom chamber, there is a school of thought that these are not lone diagnoses. They are the tip of the iceberg or a symptom of a more systemic problem. So the more medical problems you have, I would believe you require more surveillance or screening. So that's what I would focus on. So if you have diabetes, you have high blood pressure, you've had prior strokes, you have heart failure, then these are the type of patients that we tend to focus on more to look for rhythm problems, because it's not just the rhythm problem, it's the company it keeps.
Yeah, that's very well stated. And that's one of the things that we have a challenge in cardiology is when symptoms are intermittent and they're not having the symptoms when we see them, how do we figure out what's going on? And that can be the challenge, but it's also there's some baseline information that can really reassure us. They can bring those worrisome cases, those causes down. So, I often, like all cardiologists, I see patients with palpitations, and, I will tell them, look, if first of all, there's a story. If they're like, oh, I had, my heart skipping a beat and, didn't have chest pain, didn't have shortness of breath, didn't pass out or feel like they're going to pass out, already my level of worry is less. If their EKG is normal, my level is less. If their echo, if their heart's structurally normal, my worry is a lot less. So at least we can, start categorizing these people. Whereas that same story in somebody who's had a heart attack, they have an ejection fraction of 20%, their EKG's abnormal, all those things, my level of interest in pursuing further goes up significantly.
Right. It helps you risk stratify the patient.
Exactly.
Right.
Exactly. So, even if we can't actually identify what the issue is, which sometimes we can't, like they have palpitations periodically, but if we can know those things, we can at least say, hey, that's benign.
Right.
Beautiful. Yeah. So, this leads into the atrial fibrillation. I really want to spend a lot of time on atrial fibrillation today. I'm sure your day is just filled with atrial fibrillation. And atrial fibrillation is such a complex issue. AFib, first of all, we're all overrun with AFib. Like anytime, even though I'm not in the hospital anymore, anytime I was in the hospital, on the hospital service, I felt like I was running an AFib service. Like, 60-80% of my patients in the hospital would be, we were seeing them for AFib. It's same thing in the outpatient. I mean, the data is really striking. It's increasing at epidemic levels. You said earlier, what was the statistic you used of percentage of people that would have AFib?
So data shows that 60% of people past the age of 60 are going to develop AFib. And those are just the ones that have access to healthcare and are able to get a diagnosis.
Yeah. So, that's back to the Apple Watch and those consumer monitoring devices. Their claim, and of course there's anecdotal cases where this is the case, is that they would be able to notify people that they have atrial fibrillation and they would be able to get stroke prevention interventions, and that's true in certain cases. There's a downside of it. It may not be accurate. It can lead to worry, to unnecessary workup, all those things. But that's one aspect of atrial fibrillation. But atrial fibrillation is just such a challenge for us because one, it's wildly expensive. I mean, I saw data not that long ago that said it challenges heart failure as a cost of care.
Right.
That's, and heart failure is the most expensive or the highest cost problem that Medicare, pays for. The other part of this is atrial fibrillation is potentially deadly. We know people with atrial fibrillation, on average, 5 times higher risk of stroke, 3 times higher risk of heart failure, doubles the risk of dementia and early death. All of these, issues, and yet treatment of atrial fibrillation is very challenging. And I want to talk about this. I wrote down some quotes from the Heart Rhythm Society, and for the audience, Heart Rhythm Society is the preeminent professional organization for electrophysiologists. So these are the people. This is the organization that the EP doctors, belong to, and guide them on the best care. And these are quotes from a document from HRS. They said, there is a clear need to improve AFib care and its delivery. Underdiagnosis, inadequate treatment, and an improper care variation is widely prevalent. So I want to spend some time on that because you and I talked about this when we first met as well. But let's just start with that first question. Why are people often not getting the best treatment for AFib?
So just along those lines, so less than 10% of people with AFib actually make it to an electrophysiologist. I mean, just imagine how staggering that data is. Less than 10%.
So wait, you're an expert at treating atrial fibrillation, and you're seeing 90% of the people with it aren't seeing you.
Correct. Yeah, just think about that.
Why? Why would that be?
So I think it stems from awareness and education. And the education has to start at the level of primary care. And what we want to do is provide access to the primary care doctor. They should be able to send their patient directly to an electrophysiologist. And we can then start the workup, basic echo, stress test. I mean, 20% of AFib cases can be ischemia related, but we can help expedite that workup as opposed to having the middleman. So what we want to do is educate, make other providers aware of the need to send the patient directly to an electrophysiologist. The earlier you send the patient to us, the better the outcomes are, whether it's ablation, whether it's medications. lifestyle modification is a big part of AFib care, which a lot of providers tend to forget. And I think that's where you and I can collaborate well.
Yeah. Yeah, we'll do a deep dive into that as well. So, I've been a cardiologist for a pretty long time now. 23 years since I started my fellowship in cardiology. And I don't know if there's areas that have changed as wildly as atrial fibrillation in that time. Like I remember, maybe not as a fellow, but as a resident, people with AFib would get admitted and put on procainamide and drips.
Those were the days.
Yeah,
yes.
and we'd cardiovert the snot out of them. They just because we didn't have anything else. And then when I was a fellow, that's when ablation came out, and we started having better options. But who should manage atrial fibrillation has evolved, and there are varying opinions. I remember one of my attendings when I was a fellow would be very upset when we got consults for atrial fibrillation in the hospital because they felt like the hospital internal medicine service should be able to manage AFib. I always thought, but we can manage it better as cardiologists. But you're telling me there's another level, like electrophysiologist, and I agree with that. Like, what would you say that somebody that had an Apple Watch that tells them, "Hey, I'm having AFib," and they've never been diagnosed with that? Would that be appropriate that person would schedule with an electrophysiologist?
Absolutely. Okay. And that allows us to do the workup going forward. And to your question about who should be taking care of the patient, I look at it as a team approach. I look at it as a heart team approach, where each doctor has their role. The beauty of modern medicine is the advancements of medicine, for good or bad, have made it impossible for a single doctor to keep track of all the advancements all at the same time. So division of labor and being a master of one skill is probably the way to go. So I love having my general cardiologist on board. I love having my heart failure experts, and getting an electrophysiologist on board for your heart failure patient is, I think, of incremental benefit, because rhythm control in heart failure patients is and should be appropriately part of goal-directed medical therapy. The cadence of the heartbeat, the synchrony, critical.
Let's talk about that, rate versus rhythm control. So that's these are two of the pillars of treatment of atrial fibrillation. In the day, when I was a fellow back then, we had data that showed that outcome was the same. Like, getting people out of getting people out of AFib versus just rate controlling, slowing the heart rate down. And as long as you had, stroke prophylaxis treatment for them, that the outcomes were the same. But that study was done 20-some years ago. Right?
Over 20 years ago. It was in 2001.
Okay. Yeah, no, let's not date me now. But no, things have evolved dramatically since that time. Especially in regards to ablation. I don't know that medications are much different now than they were 20 years ago, maybe a little bit, different, but the real change has been the effectiveness of ablation. And when it first came out, it was complex, right? People would be 4 to 6 hours, and, it wasn't always, didn't have the success rates. Now, this is a procedure that with a really strong track record. Tell us a little bit more about ablation and how that fits in with the rhythm control that you're talking about.
Right. So just going back a little bit, a lot has changed in the world of AFib in the past 20 years, starting with our understanding of AFib, the mechanisms. There's still multiple different theories, but the predominant one is the pulmonary vein origin. Ablation has evolved significantly, not just based on our understanding, but our equipment. So just to compare and contrast, the procedure used to take anywhere from 6 to 9 hours. Now we're able to do it anywhere from 1.5 hours to 2. Success rates were about 60%. We are close to 85 to 90% if patient is sent to us early on. Complication rate used to be close to 4 to 5%. We are now less than 1%. I mean, that's a dramatic decline. It's incredibly safe. Patients are doing so much better. We are now even looking at same-day discharges. So it's come a long way. Not only have the techniques improved, the efficacy has improved, complication rate has gone down, but I feel that we can retard the progression of the disease process if the patient is sent to us early on.
Yeah, so and there's data to support that, right? In early intervention.
Absolutely.
Strategy.
So the minutia, just to go into that, the fine print of the study 20 years ago, it was a mortality-based study. But what people don't realize is the morbidity associated with AFib. It leads to increasing heart failure, worsening heart failure, valve problems, and there's increasing data about dementia. And I feel there's nothing worse than developing dementia early on from a treatable condition. I mean, it's an absolute disservice to the patient.
Yeah, and that's one of the challenges of practicing evidence-based medicine is that while the evidence is essential, it doesn't fill in all the gaps. You know, the classic example of that is statins and preventing cardiovascular events. And, you know, the detractors will say, well, there wasn't a lot of, you know, the benefit in primary prevention wasn't dramatic, or the benefit in women wasn't dramatic. But what they don't realize is that, you know, atherosclerosis is a decades-long process. These trials are 5 years at longest. And we can't afford, yes, we'd love to have 30 and 40-year outcome, but we're never going to have that.
Right.
So we have to look for other indications. Let's talk a little bit more about ablation, because people know this. I have patients come in to see me with atrial fibrillation, and they will say, like I had one this week, well, I consider it ablation, but I will only do the pulse field ablation. And I'm like, that was in the New England Journal like 2 months ago. Like, where did this come from? Tell us about the different, strategies. I mean, ablation, cryoablation. What's the difference, and how important is that?
So currently we have 3 modalities available, and like you said, one just became available. So historically we've had the heat ablation, which is radiofrequency, and then we have the freezing modality, which is called cryoablation. And then more recently we have pulse field ablation, which is nothing but high frequency ultrasound. I think personally they're all equally efficacious. We're getting still more data about the pulse field ablation. And I think that'll take years, to gather, especially when you apply something new to widespread population. Relative risk of complications is pretty much the same in all of them. The procedure does not change significantly. Timing-wise, it depends on what kind of substrate or patient that you're ablating. Early on, I think it would not make a significant difference in how long it takes to ablate, whatever modality you pick and choose. And then once you start going into the more persistent forms of atrial fibrillation, there's various schools of thought, various techniques that we use. It's not as simple as you just go around the pulmonary veins and be done. There's a lot of complex mapping involved. So if I was to summarize, it's a very sophisticated procedure, takes a village, but I think all 3 modalities are well adopted. There's multiple vendors available, and it's something that you need to discuss with your EP if you're thinking of going forward with it and decide what's best for you.
One thing I emphasize to my patients is new isn't always better in medicine,
right.
And I've been down this route. There used to be the idea of this keyhole surgery for bypass surgery, where they were just using just little incisions and to do the bypass, and it sounded great, like to open up, do a sternotomy. That's not very attractive, right? Like we don't like that. But early on, as exciting as it was, what I noticed is, one, people had a lot more pain with the, with the minimal incision because it was between the ribs. Number 2, they were more likely to not get adequate bypass because the surgeon didn't have complete access. And not that that's not a good technique now. I don't know anything about it. But my point is, new, if you don't have other options that are proven to be effective, okay, we got to do something. But new, when you have an effective solution already, I would be cautious with that.
Right, and we're still learning. It's pretty new on. I've done a few cases of that. It's exciting, but we'll see.
Yeah, we'll see. I like that. So, there's 4 pillars of atrial fibrillation treatment. Number 1, stroke prophylaxis.
Yes, the most important.
Most important because, stroke is as we talked about, 5 times the average, depending on the risk score. It could be up to 12 times higher risk. And, you and I have been, we have had experiences where the stroke from atrial fibrillation is devastating. They often are big strokes, not ones that, I had a stroke, so I'm going to treat this. So we're really cautious about that. We spend a lot of time, talking to patients about what those risk benefits of, blood thinner medications and things. Rate control. Atrial fibrillation, often the heart rate goes faster. If we're not trying for rhythm control, then we need to slow the heart rate down. But rhythm control, when we first met, you told me about a contemporary approach to atrial fibrillation, and that's what we've talked about today. Tell me more what you mean about that contemporary approach to rhythm control of atrial fibrillation.
Yeah, so what I meant by that was early diagnosis and treatment. So back in the day, our guidelines were different then. You had to fail a medication to be considered for ablation. Things are changing now. Ablation is now a class 1 indication, especially in heart failure patients. And why would you resort to medications, and all medications have side effects, if you have something more definitive available, something better available, something safe available, and then the patient doesn't have to be on long-term medications? You can avoid development of long-term effects of a rhythm. You can prevent heart failure from happening or worsening or hospitalizations. So that's what I meant when I said contemporary care. Give the most or the safest, the most convenient, the most newly available treatment that's available in the market. Your patients should have access to it. You need to educate them, and then it's a shared decision that you make with your patient after discussion with pros and cons.
Yeah, I love that. So the 4th pillar of treating atrial fibrillation we talked about or alluded to earlier, and that's risk factor modification. And risk factor modification for the audience is just treating the potential underlying drivers of atrial fibrillation. And we know there are several of them, but we also know that treating those can be wildly effective at optimizing outcomes from atrial fibrillation. From our first conversation, I was really struck by your passion for great patient care, and you talked about a whole person approach.
Right.
Tell me more about that in line with risk factor modification.
So whenever you look at any medical problem, I would say, but let's just talk about cardiovascular. We always divide it into modifiable and non-modifiable risk factors. Modifiable risk factors is what you can do something about, and that's where lifestyle modification comes in. So pertaining just to atrial fibrillation, there's various schools of thought and mechanisms. One of them is, of course, weight-related, smoking-related, sleep apnea. All these things are known to worsen AFib. Alcohol is known to be an obvious trigger for atrial fibrillation. So once again, it comes down to a team approach with the patient. They have to do their part so that you as a team can be successful at maintaining sinus rhythm. I as a doctor alone cannot be successful if the patient doesn't do their part. So that's where lifestyle modification comes in. You must treat sleep apnea, must lose weight, minimize alcohol intake, daily exercise, healthy eating. They're critical.
Yeah, there's a group in Australia that has really been the leaders in showing us those outcome benefits, and their risk factor modification, when people were able to lose 10% of their body weight, when they were able to get more fit, when they were controlling their blood pressure, their cholesterol, their blood sugar, insulin, they were quitting smoking, minimizing alcohol, treating sleep apnea. The outcome benefits were dramatic. 5 times in the CardioFit trial, the group that really optimized all those things, 11 times less recurrent atrial fibrillation. I've always been struck, 1, by how effective the risk factor modification is. Number 2, how little patients are told about those potential benefits. And then number 3, how crazy it is to me that how effective ablation is when we're not even treating the underlying causes.
Right. Absolutely. And I hear this all the time in my clinic. Oh, I have bad genes. I'm doomed. Well, studies have shown that you can decrease your risk of cardiovascular disease by 50%, no matter what your genetic makeup is, if you eat right and you exercise.
Yeah, that's something I talk a lot with my patients about. And it's about 25% of our health outcomes, our longevity is determined by our genetics. That's not modifiable. It's not actionable, but that does not need to be your fate. And, oftentimes just letting people know that they have power over this, that
Absolutely.
They can't just, they don't have to just lay like the bugs that lay on their back and wiggle their arms, like they can actually take steps in this and these can be really effective. One other thing that is we don't talk about as a pillar of atrial fibrillation, but I just want to touch on briefly. You'd mentioned earlier quality of life. Like I don't know if I take care of a heart problem that affects quality of life more than atrial fibrillation, and I think it's for a lot of people. It's that periodic nature of it where it can come from anywhere, any place, and that gets in their head. Like I'm sure you have patients that they don't want to leave the house. They don't want to leave the city. They don't want to travel. They don't want to go to their grandchild's graduation because they're worried atrial fibrillation is going to be a factor for them. What's your approach in that situation? Like, what do you do to help those people overcome those fears and that quality of life impact that atrial fibrillation can have?
So, a common myth about atrial fibrillation is that a substantial portion of people are asymptomatic. We as electrophysiologists believe nobody's asymptomatic. It's just about how much you're teasing into and how much time you're spending with the patient. And what I tell my patients is AFib is here to stay with you. We can't cure AFib. But what we can do is give you a plan, minimize the number of episodes. And if you do have that one episode, we want to prevent the ER visit. It's not imminently life-threatening. It makes you feel bad. But we can give you a plan how to deal with it so that you're not afraid to go on that vacation that you've been planning or that cruise. So that's what I educate my patients about. And I think going back to lifestyle modification, as a team approach, it goes a long way in reducing those episodes that, let's say, medications or ablation can't necessarily suppress.
Yeah, that's been my experience as well, that when I've seen a patient that, it feels like they don't have control and they meet with an electrophysiologist, an expert who gives them effective treatment for the underlying issue. And they understand that they have some options to minimize that recurrent risk of atrial fibrillation. That gives them the peace of mind that they can go on and live a quality of life. And so I guess that would be the thing that I would, want to emphasize in the end here is that if you or somebody that you love is struggling with atrial fibrillation, either from a symptom standpoint, from a quality of life standpoint, in some way, seek help for that, because you likely have a lot more options for that. See an electrophysiologist, understand those risk factors, those things that might be triggering the atrial fibrillation, and take charge, because you have that opportunity to do that.
Absolutely. Nothing like a patient who's in charge of their own health. So if you feel bad, you haven't had a chance to see an electrophysiologist, ask your doctor. Be proactive about your health. Take over. Ask them that, hey, I want to see an electrophysiologist. I want to know my treatment options. I want to know what's available out there. And we're happy to see you.
Beautiful. So, Dr. Varma, what a joy to be here, or joy to have you here. As we wrap up, just thinking back on your experience, what your path to becoming an electrophysiologist, like you, I don't know, when we met, I just loved how passionate you were about helping people. And I'm sure that you're an inspiration to others out there. How did, tell us a little bit, if somebody else wanted to follow in the path that you have set here, what advice would you give them?
So to all those young budding doctors, the first thing I would say is something that I read from Muhammad Ali. Training is hard. Suffer now, don't quit. And you're going to live the rest of your life like a champ. You have to have the qualification. No matter how hard life may be, the one thing that nobody can take away from you is your qualification, your skill set, your education, and ultimately your spirit. So you can't let anybody dampen that. So finish your education. If you are in a position of power, you are obliged to empower others. That's a moral obligation that I feel like we tend to forget. I try to do that in my practice, and I feel dearly for other girls and women like me. If I've had the chance, I need to do everything within my power to empower somebody else. You know what they say, to be a difference, to make a difference, you have to make a difference. So follow that. You know, I'm a big proponent of that. So study hard, do well, do it once and for all, so that you can live well the rest of your life. That would be my advice to them.
Oh my gosh! Wow. I have chills after that. What a beautiful sentiment, and also I'm just so grateful that I have somebody who cares as much as you do to send my patients to that need that electrophysiologist. Tell the audience more. Like, how do they get in touch if they wanted to see you as a patient? How would they do that? Where would they
Google
go?
me.
Okay, Google. I love it. That's the answer. Or chat. Maybe ChatGPT. I don't know. Everybody else is doing ChatGPT. Well, thank you, Dr. Varma. It's really been a great pleasure having you here.
Thank you.
And I just thank you for everything you do for all of us.
Well, I appreciate it. I love being here. And I think the best results from this podcast would be a proactive patient. Educate yourself about your medical condition. There's nothing more like it. And just remember, it's a team approach. And don't be afraid to get a second opinion.
Beautiful. Thank you.
Thanks.
All content created by me and HealthspanMD is for general informational purposes only and is not the practice of medicine. No doctor-patient relationship is formed. The use of this information is at the user's own risk and is not a substitute for professional medical advice, diagnosis, or treatment. Hi, I'm Dr. Hurst. We created HealthspanMD for people who are dissatisfied with healthcare. Common complaints about healthcare include difficult access, poor communication, rushed appointments, disease-focused or sick care with little interest in helping people get or stay healthy, and little to offer beyond a prescription or a procedure for optimizing health. This type of healthcare is unacceptable, but most aren't aware that they don't have to accept low-quality healthcare. HealthspanMD provides exceptional medical care. That means appointments when you need them, time to talk to your doctor, get your questions answered, understand your problems, and get a clear plan to achieving your health goals. But it also means a comprehensive, proactive approach to your health that goes beyond prescriptions and procedures. As a HealthspanMD patient, you will get our expert, physician-led team of doctors, health coaches, dietitians, exercise specialists, mental health, and other health professionals to help you take advantage of your best opportunities to prevent, treat, and even reverse disease. And you may be eligible to have our care model reimbursed by Medicare and some commercial insurance. If you're no longer willing to settle for low-quality health care, schedule an appointment at HealthspanMD to experience healthcare as it should be.